Complete the show, making me a showstopper. Right. Myself, Dr. Naresh, I am from Bangalore. I will be talking about infection in arthroscopy. Infection is a very rare in arthroscopy, comprising of less than 1% of the cases. And if it treated early, it will give good results. More than 95 to 100% will be excellent. And if not treated properly, will be leading to dreadful complications like arthropfibrosis, permanent contractures, and even damage completely to the joint as well. Coming to the risk factors, the main risk factor is the intraarticular injections. There is a study by Werner et al., which was published in 2015, states that if there is an intraarticular injection 3 months before, the risk will be more by 3 times. If it is 6 months, then it is 1.5 times. Surprisingly, I was also seeing the type of graft also can cause infection. So autografts are more prone for infection, and in that also hamstring is more prone for infection. See, the study by Goud et al., they are telling that the infection is because of the suture which is inside the joint, which can be a reservoir for bacterial growth. Another theory by tibial tunnel theory by Fong et al., he was telling the infection will be from outside to inside. The blood collection behind the skin can be cause of infection which passes through the tunnel into the joint. Other risk factors including obesity, male sex, old age, tobacco usage. These are to be optimized before we are treating an infection case. Surgical time, as everyone knows, less than 45 minutes is an ideal time. If it is more than 45, 3 times chance of infection, and more than 90 minutes, 6 times chance of infection. Most common causes in shoulder arthroscopy are rotator cuff tears, and least are the Bankart repairs. As everyone knows, the most common is staph aureus. Whereas in knee arthroscopy, again, staph aureus is the most common. Pain is the most common symptom when a patient comes after infection. And if you see the amount of symptoms with which the patient comes to the OPD, pain is the most common symptom, but only 60% of the patients have local signs of redness, warmth, and other signs. Only 50% will have secretions, and only 32% will have fever. So there should be a high index of suspicion when you are looking for a patient with infection, or whenever there is a patient who comes with a pain after the surgery. So routine lab workup, CB, CSR and CRP has to be done. Synovial fluid analysis I will be explaining in the further slides. MRI will be helpful in staging. X-ray will very rarely will be helpful. This is early diagnosis and appropriate treatment is the main key for treatment. If there is a patient with long-lasting pain and subacute sign of septic arthritis, you should have a high index of suspicion and treat him. As I told you earlier, when there is a joint aspiration, when you do, if the synovial fluid analysis is more than 1 lakh count is there, turbid texture and neutrophils, then it is 100% infection. You have to do as early as possible, debride it, remove all the hardware, or if you can see the texture of the hardware and you can plan accordingly. Empirical antibiotic therapy should be started once you remove and send for culture sensitivity. If ESR CRP is more than 2 to 3 weeks after surgery, in case of if synovial fluid is not properly there and the count is less than in between 20,000 to 1 lakh, ESR CRP will help us in planning the surgery. Definitive diagnosis is the culture of organism and you have to treat. How to treat is by joint aspiration, surgery, and should be done within hours if it is a complete infection. 5 tissue samples should be taken during the surgery and sent for culture sensitivity. We should wash with minimum 10 liter saline. And extensive lavage, debridement and synovectomy has to be done, pannus removal and everything has to be removed. So synovectomy, if I am saying synovectomy, it has to be removed all the corners, suprapatellar pouch, medial corner, lateral corner, and if you have to go posteromedial and posterolateral as well. So we are removing the synovium from the suprapatellar pouch and the posteromedial corner once there is a sign of infection. So drain can be used. Drain will be helpful in 2 ways. One, we can decrease the pressure of the joint, and second, we can see amount of secretion, how it is. Basing on that, we can tailor our treatment. Surgical strategy should be based on the stage of infection. If it is severe stage, you can do open the joint and remove the synovium rather than roaming around with arthroscopy, because open synovectomy is always better, and always aggressive plan should be treated in surgery. Second look you should always be there. And suction irrigation and other things like hydrogen peroxide, povidone iodine, other things, vac dressing should not be done. Antibiotic therapy, if you are using intraarticular antibiotics, should not be used because they are of chondrotoxicity. Only vancomycin can be used in a small quantity over the graft as a wrap to decrease the amount of infection before the surgery as a prophylaxis rather than the intraarticular antibiotics. If you are using IV antibiotics, second generation cephalosporin should be used. This is a theory which is recently started, hit hard and hit early strategy, where they will add piperacillin, tazobactam, 3 gram IV TID and amoxicillin once the synovial fluid has been taken, and for 2 weeks, then followed by oral antibiotics. However, whether the hardware has to be removed or retained, after debridement on the left side, if you see an intact ACL with a normal texture, then we can leave the ACL graft. Or if it is like on the right side where the graft is completely damaged or gone, then we have to remove all the hardware, everything has to be done. Precautions, a sterile environment is very important. Usage of antibiotics, as I told you, vancomycin soaked graft is helpful. Rehabilitation, vigorous physiotherapy to be done once the surgery is done to avoid contractures. This is a flow chart showing about how to treat an infection. As I told earlier, clinical examination we have to see, and then blood test will help us. Elevated infection parameters, you can have synovial fluid aspiration to be done. Basing on that, you have to do the surgery. Finally, the take-home message is high index of suspicion is required when you are dealing with infection cases. Early diagnosis and treatment is the key for surgery or key for good outcome. Synovial fluid analysis will help us to find the culture organism. Antibiotics should be tailored according to the culture sensitivity. Hardware and graft has to be removed if more signs of infection and the graft is loose. Debridement and synovectomy is the treatment, and vigorous rehabilitation once everything is removed is final stay. By this, I thank you, and thank you everyone for giving me this opportunity. And
Dr. Goud.